the number of notifications that were coming in while I was driving was so distracting to me that I lost it, ripped it off and just threw it.
If I hear those certain ringtones from a pager, even if it's on an ad or something in public, I literally have PTSD. My heart skips a beat. Your patient is dead. That's the only thing they wrote in the message on the thing. It says, your patient is dead. I'm like, what? If you think of from start to finish, let's say you're doing a full mommy makeover, right? You're doing breast lift, breast augmentation, maybe doing some liposuction, maybe fat grafting, tummy tuck, labiaplasty. I mean, think of all the steps, the technical steps there are for each one of those surgeries. And you're doing that in order, right? And you pretty much probably do it the same every time. It's like baking a very complex cake, but you cannot miss a step, right? If your focus is somewhere else, even for a millisecond, I mean, it could be technically disastrous, right? Either you're going to create a permanent change on someone that it's going to be hard to fix, or there could even be worse than that, right? You could cause a complication, especially if you're doing liposuction and something happens, right? You go too deep or whatever it is because you're not paying attention. We saw that happen. There was a board certified plastic surgeon in Ohio. She lost her license because she was doing live streaming of Instagram and Snapchat and was doing things like chin lipo, lipo live, answering Q&As, and she went into bowel. I mean, it happened several times until she ended up losing her license. And, that's, for me, the standard is, like you said, always focus on surgery. I never do live Q&As, I personally choose not to do Snapchat, things like that during surgery, because I feel like surgery is the most important thing at that time.
Yeah. And I feel like if you have somebody there who is taking video of you working, and that they're going to edit it later, or if you're talking at the end of the case, I feel like that feels fine to me. Totally. But yeah, the actively operating while having active discussion with people, that feels like it would be very distracting.
For sure. I think it'll throw you off a little bit. And, I think about this, so a lot of people I think don't know what happens in an operating room, when we're in training, right? If you think about it, you're with your attending, there's probably a senior resident or maybe the chief resident in the case. There's a junior resident, there's probably a medical student or two, there's 5 or 6 people that are on the surgical side. Yeah. Then you have your scrub tech, you have maybe 2 scrub techs, you have the anesthesiologist or anesthetist, you have the circulating nurse, you have all the staff in this room. And there's a lot of teaching moments. You and I learned from other surgeons. It's a hands-on apprenticeship type of a situation for 6 years for us. And that's how we learn. So, we're talking, we're being taught while we're doing, mostly I'm sure you're getting pimped, right? They're asking you questions what's this blood vessel? Where does it connect? Stuff like that. But they're doing that while they're operating. And so it's a skill I think that we do develop, and, we're able to educate and do that. But I agree. I think taking your focus off and talking to someone who's not even in the room and trying to answer questions like that, it just seems too distracting in my mind.
Yeah. Well, with education, at least they're talking about, the active anatomy and what they're up to. At least it's topical instead of talking to somebody on a screen on the other side of the room. It feels a little different.
Yeah.
Yeah.
So I think that's super interesting that you bring that up, just in terms of time management as surgeons, because you're also a dad, you're a husband, you're a dad. Obviously, you've got friends, you've got colleagues like myself, your friend and colleague, and other people that you're trying to juggle in your life. So how do you, outside of notifications, how do you balance your work life, Sean? How do you separate? When are you I'm done, I'm going home today, I'm not talking to anybody else about work? How do you do that?
I think, honestly, getting away from my phone is the hardest part, but the most effective thing. And I think that all of the app stuff that you have, I'm going to cut off my Instagram, I'm going to do 15 minutes or whatever. They have the cutoff, but you can get through it by pressing one button. It's none of that helps, because I just know that I just have to double tap to get into it when I'm out of time for that day. So I think that when I'm coming home, one of the things is just get myself separate from my phone. And the thing that's actually been the most helpful to me is an Apple Watch, just because the functionality of it is kind of I'm not answering stuff on TikTok off of my phone, but I feel like I have to have a connection just in case I get an emergency phone call, just to be there for my patients. I get anxious when I'm separated from it. So I found that has been helpful. And I see that, you see all these ads for brick or whatever else is coming out, whether basically like turning your phone back into a landline voluntarily, getting rid of all the extra doodads other than being able to like text or call or whatever you set it to. I feel like people are really starting to see that they are so distracting, but for us, you just like, I can't be away from it at all times because I have to be connected in so many different ways. And you want to be connected, right? It's a joy in many ways, but then when it starts to spill over, it really becomes an issue. But setting aside time, trying to think ahead and plan with friends for a barbecue or just a Zoom get together to have, a beer with somebody you haven't seen who like lives in California or lives across the country. Just trying to really set aside that time to continue to foster those relationships, because while we have so much connection through social media, it's different, right? You feel like you're interconnected with so many thousands of people, but it's still, they're not going to pick me up from the airport. They're not going to help me move. Probably. I mean, maybe I haven't put it up on Instagram to like ask them if they would help box up my house.
They probably would.
Yeah. I don't know. Crowdsource that, but it's just it's a different type of connection. So, friends from graduate school and friends from medical school, and just making sure that you're touching base. But I feel those really close friends, even when you have huge swaths of time, anytime that you touch base with them, it's like the connection is immediate. They're just like,
oh, totally.
Your people.
Yeah.
You found your people.
You just pick up right where it left off, even if it's been a year or 2 years, or maybe a month, whatever it is. I totally agree with you.
Yeah. Though my Apple Watch actually took like a ride in the back of my car for like 2 weeks. I was getting new glasses. And while I was driving down to the optometrist, I felt a buzz on my wrist for a notification. So I look, there's nothing. I was like, very strange. I don't know why, sometimes you have those like phantom buzzes from your phone.
Oh yeah, for sure. Like in your pocket.
Yeah. So I was like, okay, maybe it was a phantom buzz. And then like 20 seconds later, it buzzed again. And I look at it, it was nothing. And then it started buzzing like very consistently, but nothing was happening. I don't know what it was. I don't know if it was trying to tell me I was having a heart attack or I got like 50 emails. I'm not sure. But when you clicked the crown, like nothing was coming up. And the number of notifications that were coming in while I was driving was so distracting to me that I lost it, like ripped it off and just like threw it, like launched it into launched it in the back of my car, because I was just like so overloaded, so overstimulated from that buzzing and the feeling that like I should be seeing something, I should be doing something, and that there was nothing to do, that it like drove me to like the point of insanity to like just like launch my Apple Watch. Had to like dig it out of the trunk like a week later and charge it up.
That's funny.
Yeah, but
I haven't worn my Apple Watch in a while, but I like your idea of the notifications. Okay, well, along the lines of annoying, right? Dude, okay, I want to bring up one thing. You're gonna know exactly what I'm talking about. In residency, pagers. Did you guys have pagers still when you were in residency?
Yeah.
Dude, in 2018, were we still using pagers?
Yeah.
I still get palpitations, dude. Like, if I hear those certain ringtones from a pager, even if it's like on an ad or something in public, I literally have PTSD. Like, my heart skips a beat.
Oh, yeah.
Start breathing a little weird, Yeah.
Because
I remember just getting those in the middle of the night, dude. You're so tired. Even up, you're probably working for 16, 18 hours that day. You're on call that night. You get a call at like 2 a.m., Because there's some nights where you're literally up all night anyway. You're just there. But you're home. You think you can get some sleep. 2 a.m., 3 a.m., you get that pager, and that just wakes you up. And I just, oh, man. Like, it does things to me still thinking about it,
Yeah.
Check my heart rate right now. But
yeah.
Because you just don't know. Like,
it's unbelievable.
Yeah. It's not a fear at all, but it's like, you're almost like trained, like Pavlov's dog's like, okay, like I got to go in, or answer this call. And you don't know, is it going to be like a bilateral hand amputation that has to be replanted? That's going to take the next 2 days. Is it, an infection? Whose patient is it? You got to call the attending. You got to go see the patient in the ER. Like, it's a lot, dude.
Well, I mean, it's one of those things you get trained into hearing. Every time you hear that noise, you have to do something, right? No one has ever paged me to be like, free cake. Right. It's never something good. It's never something amazing. True. Like, your patient from earlier in the day called to say that you did an amazing job. Right. It's like, it was never positive reinforcement. So anytime you hear it, you just pray that it's like a Tylenol order or like something super silly and nothing too
Go back to
terribly
sleep after.
crazy.
Yeah.
Yeah. But we used to have, did you guys have the call pagers to like pass off to each other? Or did you just have your own personal pager?
I had my own pager the whole time. So on certain services, they had a certain pager, like transplant or, burn ICU. We had a specific pager for that.
Yeah.
But I had my own pager, yeah.
Yeah. So for some of our night coverages, you would have like your pager, and then you would have like the ICU pager and the burn pager and the whatever pager. So you'd have like 5 pagers, right? You can barely keep your pants up because it's just a million, it's just a million pagers. Sure. And then sometimes multiples are going off at the same time, 2 phones. You're like, it's madness. It's like, why would we ever do this to anybody?
That's so true. Yeah, it's, I think about, as a plastic surgeon now, what I do on a daily basis, in terms of like level of acuity, right? Like how critical are things that I do, the decision I make? Is that a life or death situation? Is it limb or limb saving? Like I don't make those decisions on a daily basis anymore. Like I think as residents, you're making those decisions. Like I said, you're in the ICU, you're in the burn unit, you have patients coding, and you're running that. So as a plastic surgeon, it's nice now. I feel like I don't deal with that a lot. But what I would say is if it does happen, especially when I was doing hand, I feel very comfortable taking care of things. Like I never didn't get my blood pressure up. I was like, yeah, let's do it. You keep that clear mind and you can come up with a plan quickly. And I think all that training we go through was for that reason, right? So you can make clear decisions, the right decisions to save a limb or a life.
Yeah, absolutely. Yeah, my wife comments on that. We've been in a couple situations where she was at school and had to call 911 because like a child had a seizure or something. And then she's talking to me on the phone. She's like, you're very eerily quiet and very, it's like, it's worrying me that you're so calm in this situation. And it's like, as the acuity gets higher, it's like I get calmer as time goes on because you're, when you're doing all of the work in emergency department on trauma, you find that all of the getting frazzled gets you literally nowhere. It's just take a moment, make the right decision, do the right thing out of the gate instead of trying to do 8 things that aren't going to be particularly helpful.
My PA that works with me, Meg, one of our PAs, she's awesome. She trained at NYU. She did cardiothoracic surgery, ended up doing EP stuff. But she told me her attending, because they'd run to codes all the time, her attending told her this piece of advice. She's like, don't ever run to a code, walk to a code. Because everybody's going to have their role. But he's like, you need to like focus, be ready, right? Like you're saying, like like what your role is going to be there and how you're going to help direct things. And so if you run into the situation frazzled, like you're going to probably make a bad decision. So he's like, don't ever run to a code, walk.
Yeah. Makes sense.
You kind of prepare yourself. Anyway, I think even in life, I feel like I don't try to run into clinic or run into surgery, right? It's always make sure you're ready and prepared. And, weird stuff can happen in surgery. We see that all the time, but again, having the training and stuff to be able to deal with that, I think is the most important thing.
Yeah. I got a question for you. So
Okay.
what is like the worst page you ever got in residency?
Oh, that's a good. Oh, I remember. I know exactly the page.
I was like, we all have that one page.
I have this one. So I was cross covering, I think I was a second year resident and I was covering like vascular and I was in the ICU and gen surge and all this stuff. And I get this, and I had gotten sign out from all the services, right? They all go home at 6 p.m. So I'm there in the hospital and I get this page and it's a nurse on whatever floor, 8100 or something. She says, your patient is dead. That's the only thing they wrote in the message on the thing. And it says, your patient is dead. I'm like, what? I'm like, this is the first time hearing. I heard no code. I'm like, what the heck? So I run up to the unit. I go up in there. I go in the room. The patient's dead. I don't know who this patient is because she's like on different service. I hadn't gotten signed out about this patient. Patient totally dead, cold body. And so I go grab the nurse. I'm like, you guys can call codes. They're like, oh no, we were expecting her to pass away. This wasn't anything, like we were expecting it. Like she was, kind of end of care type thing. They were just kind of waiting for her to die. She's like, I was just messaging you to tell you that the patient finally passed. I'm like, thank you, but I had no idea. Like maybe next time,
a little better on the sign out, maybe from the other team as well.
Out, and then maybe like a little less of aggressive message. But oh my gosh, so I had to do the declaration time of death and all that stuff to document it. But that was probably the worst one I got because I did not expect that at all.
Yeah. I was like, that's not the page that you want in the middle of the night. That'll wake you up quick.
Yeah.
Better than a cup of coffee.
How about you, Sean? What's your most memorable page?
So I was a senior, like chief resident at the university on plastics. We have a team of like 3 or 4 residents at the time. And I get a page at like, I think it was like 2 a.m. It was like middle of the night. And I was at home. I wasn't even like in-house at the time. And the page that I got was severed arm in the operating room. Like, please advise. It's like nothing else. Just like severed arm. Like, just want to let you know that there's a severed limb, so you should probably be involved.
It's on the back table. Can you come look at it?
Yeah, can you come take a peek at it? So I called my 5th year. It was Dr. Melissa Mueller, and we came in, and we literally went in the operating room, and there was an arm, but there's no patient. This is literally an arm.
Wait, what? Just an arm?
Yeah, there's an arm in like literally somebody's
just
arm.
An arm.
Just right here, middle of the humerus, just elbow, hand on a table, and Melissa's already there, and she's scrubbed in, and she's kind of marking everything. I was like, I mean,
what are we doing?
We probably need another piece to this puzzle. And apparently,
where's the rest of this?
It was a motorcycle accident, and his severed arm was like number 4 on the list of severity of things that had to be dealt with. So he had already gone with like trauma surgery for like an X-lap to take a look at his belly because he had bleeding, and then he had pelvic bleeding, so they had to send him to IR to get embolized, and that's where he was. It's like he had left the operating room to go to IR, and they were like, well, if he comes back, then you get a shot at putting the arm back on. But it was like surreal being in an operating room with like the patient. It's like you have some of a patient, but there's no monitors, which was something
that's a little weird.
It's super weird, and it's something that probably other people really wouldn't think about, right? It's like when we're in an operating room and when you're actively operating, there's that cacophony of just beeping and blipping constant and all the stuff, and we're used to hearing it, and it feels good in a way because it all like makes sense. Like patients alive, patients doing well. So when we're working and like tagging everything on the arm, it's just
quiet.
Silent. And it's the middle of the night, so it's like skeleton crew. There's nobody else around, so it's just like silently hanging out in an operating room, like waiting for someone to come back. And of course, when they come back, it comes back with like, there's 12 people, kicking the door. Yeah. There's 1 million people. Everybody's rushing in. It's just like all of a sudden it feels like a true operation again. And we were able to like reimplant his arm. But the initial period of like putting it, just tagging everything, get everything marked out when you're working and it's just silent there. It's just strange. But yeah, that was my worst page. It's my worst page. Severed arm.
That's wild.
Please advise.
There's a big part of me that, because I love upper extremity trauma and hand stuff. And like at USC, we did a lot of that type of stuff. And at Loma Linda. But there is an aspect to that, like you kind of mentioned, just that environment. Like I miss it sometimes. I don't miss being up in the middle of the night. I don't miss how long those cases take, but I love the technical aspects of it. Like even just you describing that, I'm just in my head thinking, okay, you got to stabilize. You got to either shorten the humerus, you got to stabilize the bone. You're gonna have to get all the vessels ready, the nerves. You're gonna have to probably get grafts. You're gonna have to, you maybe put a shunt in the arm. Like all these things, and like they just start coming to my head, and it just makes me kind of miss that, And I don't get to do that now as much. At all, actually.
I was going to say not anymore for either of us.
But the training, I don't know. I just, coming back to just plastic surgery in general, and we mentioned this on our very first podcast, was like, it really is the last specialty that we're operating head to toe. Because even general surgery has gotten to the point of where it's so specialized, right? It's like you're doing colorectal, you're doing breast, onc, you're doing, maybe it's head and neck type stuff, thyroid stuff, whatever. You're doing vascular surgery, right? All these things branch off of general surgery. They're not really doing everything anymore.
Well, you can go back to upper extremity trauma if that's what you want.
No, I don't.
that's what you can pivot. If that's what you want to do.
It's true. No, I honestly, I had a patient today. This is so cool. And maybe it'd be cool to hear an experience from your patients too, because I know you've got a lot of happy patients. But, I think sometimes we do what we do every day. And I wouldn't say it feels repetitive, even though I'm doing a lot of the same types of surgeries, but every body is so different.
Oh, yeah.
But seeing the patients when they come in at their 3-month or 6-month or whatever it is, and just the joy on their face to be like, the patient today, she said, you didn't restore my body after having 5 kids. You gave me a new body. She's like, since I was 13, I never had a body that I loved. She's like, I had hanging skin. I had large breasts since I was a teenager. And she's like, I've never had a body where I was like, I felt like myself. She's like, now I'm in my 40s and I finally have the body that I love. And it seems like so simple and basic, but like you think about it, that is such a profound statement, that we as surgeons, like literally changing that. And that just makes it so rewarding, I think, for me, and I'm sure for you. And like I said, you probably have some experiences like that all the time.
Yeah. I mean, with the mommy makeovers, breast reduction patients, like ever so happy, and that, it's a life-changing procedure for them, just being so much more active and just more comfortable. It's a beautiful thing. But coming in, and I feel like sometimes it's at week 1 and sometimes it's at week 2, depending on how big the surgery is. I feel like if it's a really big surgery, sometimes you walk in week 1 and they see it and they're kind of like, not so sure about this guy. This has been like a difficult
week. Mistake. Yeah.
But it's like whatever week that kind of turns on. It's like I saw a tummy tuck patient today. She had 360 lipo and tummy tuck. She said she took 2 oxy and had just been on Tylenol, and just when I walked in the room, it's just smile from like ear to ear. She just amped. It already looks great, even though she's swollen and bruised. She's already excited, can already see what the future is going to bring. And to see that, you're like, that is something that I trained to do. That is something that I, have gotten better at over the years and really kind of dialed in to be better at the craft. And that bringing this all together and seeing this patient at 1 week post-op who's just like amped and excited is so incredibly rewarding. It would be hard to give up.
For sure. That's awesome. And I can't speak for all surgeons. I think a lot of obviously like our friends that we talk to, a lot of the plastic surgeons that you and I both know, they feel very similar, right? They're very passionate about it. I do think there's a lot of people that maybe don't have that same passion, and maybe they're doing it for other reasons, and that's fine. I'm grateful that I've kind of found like the niche that I love, and it's, kind of like we mentioned, doing the kind of full body restoration or helping people feel new again. It's really rewarding. It's a good feedback mechanism, because like you said, it's like, and I look back at my practice over the last 4 or 5 years, it's like these slow iterations, like you kind of change a little bit every time. I feel like I get bored easily. I hate being stagnant. If I did the same thing every time, I'd be bored. So I'm always looking for ways, and I know you're very similar because we talk about stuff all the time, but just trying to get better every time. And then seeing a patient back at 1 week or 2 week or 3 months, 6 months, whatever, and seeing their results and saying, okay, I'm going to do this differently next time, right? Because if we just think, oh, I know what I'm doing. I got this down, right? Like if we always have that mentality, we're never going to change it. There's something that could be better. If we think we already know everything, we're not going to try to be better for our patients, And I think you and I are very similar in that. We're like, we want to always get better. Like I'm never done learning. I want to go learn from other surgeons. I want surgeons to come to me. I want to go to them and learn more and more.
Yeah, absolutely. Your goal is always to improve upon where you've been. So sitting and looking at your results for the last year, be like, these are all great. That's awesome. I'll just take vacation and just move on. That's never the goal. It's like you want to see like, what could I be doing better? Or what am I having side effects from, either medications or dressings that I'm using? What is better that is out there that I could try out to see if we can dial this in even more than kind of where we already are?
So I'm going to ask you this. What's one, and I have an example I can share, but what's one thing maybe in the last 6 months that you've taken that feedback and that you've kind of changed, whether it's a technique, whether, like I said, it's a dressing? Is there one thing you can think of? I have something in my mind, but if you have something you want to share.
Yeah, why don't you get started and I can think it over.
So, when I first started doing like tummy tucks, breast stuff, I was using just full on steri strips. So for people that don't know what those are, it's an adhesive tape, and it can be in different widths. I usually use like a 1-inch adhesive, but it has these like little strips of like, I don't know what's in there, but it makes them like, it holds tension essentially, right? So you can lay these on scars where there's perpendicular parallel to cover the scar to help it reduce tension. But I found that when people swelled a lot with the steris, they would potentially blister and have issues. So from there, I switched over to paper tapes. And I think paper tape's great. Brown paper tape, it's porous. You can put that on, little cost. But I just felt like the scars weren't exactly what I wanted. So then about 2 years ago, I switched to something called Exafin. So it's a lot like Prineo, where it's like this mesh tape and then you lay down glue on top, right? And so it kind of reacts with this mesh tape and it holds tension, but it also protects the scar, can breathe a little bit. But then I started having issues with that stuff. You know, the vendor says, oh, it's only 1% or less chance that people have a reaction to the glue, right? Where you get a horrible rash. But I was seeing like, oh, it's up to 10%. Same with my partners. We're like, man, this is like, if I have 1 in 10 patients getting a red rash, they need to be on steroid packs and antihistamines just from the tape. Like, what are we doing? You know? And so in the last, I think about 6 months, I switched to something called silk. I don't know if you've seen that stuff. It looks like a mesh. It's very white. It's mesh. It's made out of silk. So the it's non-reactive to the body, has minimal adhesive on it. And I've been using that and I've literally had 0 reactions to that. And I've been super happy with it.
Yeah.
And then so I have that on for 2 weeks. I'll do the Bridgets, the brackets to help with the tension, and then we'll switch to paper tapes. And so that's something I think in the last 6 months, like I said, I've tried to constantly change because I felt like, you know, even if I can minimize that to where 1 patient out of 10 is not having the rashes, like to me, that's totally worth it. You know?
Oh my God, super big. I mean, the adhesives, I don't know if they've just gotten more reactive or if patients are just more sensitive to it, but I feel like, especially in the last couple of years, I'm seeing more and more people who are having these these contact dermatitis, allergic reactions to these tapes. And I've been dealing with that with steri strips as well. And, you know, I've access to a couple of different types of it. You know, you get the brown ones that are stretchy, the white ones that are like more, you know, cloth-like. And I feel like both of them still cause the same issue. So for a while I was using glue underneath and not Exafin. We typically use like Liquiband or Dermabond, which those seem less reactive. And I feel like putting it underneath of the steri strip to hide the steri strip from the skin to minimize the skin on skin contact. It does help. However, you're like, then what's the point of the steri strip other than just like hiding the scar so people don't call you based on like what something may look like underneath. So I've been tending more towards just straight glue, but I know with the Exafin that you're talking about, because they used to use that quite a bit at Kaiser, and I used to hear complaints of allergic reactions to it, but the Liquiband and the Dermabond, are not as bad as far as I can tell. But the dressing stuff it's tough because you'll find patients who are allergic to steri strips. You'll find patients who are allergic to glues. I had a patient who apparently she had a horrible like fluoride reaction to Zeroform before in the past, like Vaseline based iodine gauze, which seems costed. Super safe, but she had like a spinal fusion and then it all just, you know, pussed out and opened up after she came in contact with Zeroform. It's just, I feel every single one of these dressings are kind of rolling the dice and you're trying to figure out what is going to give you the best shot that someone isn't going to be bothered by it. But there's probably not a week that goes by that we don't have somebody call who has hives or a rash, or then they need to come in. We got to get the tapes off quick, get them showered up, and then change them to something less reactive like paper tape or just like center dry dressings.
Yeah, I think there's just no consensus and we all try different things, you know, and again, cost plays into it for a lot of practices and a lot of surgeons because the cost varies. Paper tape 3M, you can get it pretty inexpensive. You can get a whole box for, you know, maybe $30 of, you know, several rolls. You know, you get one piece of silk, it's this long, it's like $30, you know, so it's just the cost. Like,
I'm not surprised that it's significantly more expensive. At least with paper tape, if they do have a problem, it comes off easy, which is super easy. Nice. With the steri strips, when they're on there, and if they have a reaction early, sometimes it's a little annoying for patients to have it peeled off on the early side. Yeah, especially if you've got glue underneath of it and it's really stuck on there.
Yeah, cool. No, thanks for sharing that. I think it's interesting. Like I said earlier, I think we're just constantly trying to, and it's even little things like this. Yeah. Or it's even like medications we prescribe before and after surgery, like dosing and timing and like, how can we make that better for patients? There's always just something to try and improve on.
Yeah. My big thing that I've been kind of changing, especially in the last year, is talking to patients about things that can preempt a problem in the future. Right. It's like you see somebody, you do a tummy tuck on them and then say that they have laxity in the muscles after everything kind of stretches back out at a year because they were a fairly high BMI. But instead of doing that surgery and then talking to them at a later point, we're like, oh, this has now happened. I think I'm now seeing people in initial consultation. And then in my own mind, I'm like, what is this patient really at a risk for, like down the line? That let's talk about adding on that fix now. Like, I feel initially when I started having consults with people, it's like, we don't know that's going to be a problem. I don't want to overcharge or like throw stuff on and just be that guy who's just, it's like used car salesman. Like, you got to get the undercoating. We don't know if you're going to need it, but it's going to really help in the future. But at least giving people the options up front, because there's so many times you talk to a patient, you're like, hey, we're doing a primary breast augmentation. You are picking a pretty modest implant. You have great skin. I don't think that oversettling or bottoming out is going to be an issue. However, if we had a problem with that, we would have to go back and do a surgery and probably put in some mesh. So what would you think about putting in mesh to help kind of that insurance policy, that protection out of the gate? And it was surprising to me. I mean, financially, I'm like, wow, $2,500 or whatever you're going to charge for the Galaflex. Seems very expensive, but people are already paying so much. A lot of them are like, hey, if this is an insurance policy that's going to stop me from having a surgery in the future, a lot of people really appreciate hearing that up front and have that from their initial surgery. And I feel like that has really helped in controlling long-term outcomes for me. And that's been a big shift in the last year. It's like, I'm not really talking to them about like surgery number one. I'm like, what could the possibilities of surgery to be, and make sure that we're really meeting those needs, so we're not running into a possible foreseeable thing that we haven't discussed, because at least that way we've discussed it. So if they buy in early and decide they want to have the fix and do it out of the gate, great. And if they don't, they knew that that was at least an option, and we've discussed that as a serious possibility, and they've made that informed decision for themselves, so they feel more comfortable with kind of how things went, instead of like, this is something that I never knew that was going to happen. Yeah. And I think, especially in the last year, Galaflex mesh for primary breast augmentations and using it regularly. And then for patients over a BMI of 30 for muscle repairs for tummy tuck, for laying the mesh kind of above the belly button, just a solid square sheet, rectangular sheet. I find that has just been so incredibly helpful, really kind of controlling outcomes.
Love that. Yeah, I don't remember the last time I did a breast augmentation, primary or secondary or whatever, without an internal bra like Galaflex. Again, and I think you bring up a good point. It's like once you've done a ton of these and you've seen the results, again, it's iterations on iterations, but you kind of say, okay, I've kind of found a trend now in my practice, and certain scenarios where if they have thin tissue, if they've breastfed and they have thin skin, they got stretch marks on their breast, they want a certain volume of implant, their breasts have pseudotosis or glandular ptosis. There's all these factors that we're like up here thinking of as we're consulting with these patients. And for me, it's always like, look, I've done a lot of these now, and I will tell you that when I don't do the internal bra, or what I've seen even from other surgeons coming in that haven't done it, and then the patient wants another consult, like I said, the predictability is there with internal bra, and it's not when you don't use it, and especially if they have poor skin quality. And so, yeah, for me, literally, I always do it. And even if the patient's young, I'm like, look, one, it's going to help with keeping the implant up where you want it to, right? And two, it does, and there has been some good studies to show that actually can potentially decrease your risk of capsular contracture. And so I think there's a lot of benefits to it. Like you said, it's for the long term. I don't want to do a case on a patient, even if it's just a primary breast aug, where I spend 20 minutes doing the surgery and I never see that patient again. And I don't care what their results are. Like, that's not my mentality, and I know that's not yours either. It's like, I want them to be happy and look good for the next 6 months, 3 years, 10 years, until they're ready to swap them out or get rid of them, right? Yeah. So, like you said, I think making that investment up front, you're already in the surgery, you're doing that, you're not going to be paying double facility, double anesthesia, all these other fees that you'd have to incur if you had to come back in to add that stuff. Just do it in the beginning, and I think part of us is we've done this a lot. We do have experience in it. And I think, you're a reputable surgeon. So I think when you advise that, you're not doing it for your own gain. You're doing it because, again, you want them to have that result that's consistent.
There's nothing worse than seeing a patient that comes back and they've got something going on that you're talking about how you're going to address it, and you just wished you had done the fix the first time, done whatever the preventative measure would have been out of the gate, and just everybody just be happy and go their own way.
Yeah. One thing that, I've stopped doing personally in my practice is I don't do periareolar incisions anymore for a lift. I feel like for me, like it's always going to be at least a lollipop to control the shape of the areola and the location of it. I kind of feel like periareolar, I did it a lot when I first started practice because I did them in training. And for me, the scars are not awesome. Even if you're using a Proline or a, whatever, Mersaline or, Gore-Tex, whatever you're doing to try and hold the areolar width, like inevitably, especially like I have patients come back in for revisions and I taken that stuff out. I'm like, it's not even doing anything at that point. We're doing a revision lift and this thing's just floating around.
Just hanging out, just waiting to be a problem.
Yeah. I'm like, what's the point of this? And I feel like I said, it just doesn't get you the exact shape sometimes. And so, patients hate it. They hate, I don't want a vertical scar on the front of my breast, And so for me, my practice has been like, okay, look, let's figure out the best way to minimize that scar, make it look as thin or almost as invisible as possible. We'll treat it with lasers. We'll pre-treat it. We will put bridgets on it, those little brackets. We'll do whatever it takes, because I'd rather you have a very nice proportionate shape and a good areola in the right location than a really elongated or really widened areola sitting too low or something, And so again, like you said, it comes down to what's the final result you want?
Yeah. I mean, there's very, very few indications for just a periareolar, in my opinion. I feel like in residency, I used to hear about them all the time. People do an augmentation. They would do just like a little periareolar to shift things around just like a smidgen. And I feel like the areola better be within a centimeter of what you're after, because it's not going to go that far. And then you're putting so much tension on it that you have to have all of these most people use permanent sutures. I've seen people do it with absorbable sutures, but anyway, you're putting so much tension in such a tight area that it has a tendency to spread. So then you have to do all sorts of scar care or tattooing or something to cover it up for so little gain. I feel like the only time that you really should be using it is if you're super close to where you need to be and you refuse to have any other, any other incision. You don't want to have a lollipop, or if you're just trying to change the size of the areola. Yes. Or if it's somebody, and you did this whole thing on conical breast, you had a discussion for tuberous breast deformity. I feel like for that,
yes,
definitely an indication, but that's really, really few and far between. And I feel like even for me, the circumvertical, if you're doing a lollipop, I feel like the indications for that are actually less than I initially felt when I was in residency. I feel like in residency, people were telling me that you could do a circumvertical for everything. And then I find that you're like, well, maybe that doesn't get you quite as much as you had hoped. Yeah. And then you end up doing a little something in the IMF, and then you're all of a sudden in a full pattern lift, but then you have a full pattern lift, but everything looks beautiful. And then we treat the scars, we do what we can for that, but at least you're getting the shape that you're after. And of course, it's a discussion with patients, but even the lollipop, I feel like it's really only moving the nipple and areola and resizing it. It's not really a shape thing. You don't get a lot of change in shape for that. You're not really bringing things together.
Yeah. Especially, you talk about, I think it was Adam's paper, about vertical excess and talking about that. I mean, you have too much vertical excess when you do the lollipop. Yeah, you're going to have all this lower hanging tissue, and you can't cinch that up. And this is all technical talk, but I agree. So in the end, it's the discussion with the patient is are you willing to accept these things? And so I think as you've done this more and more, as we've done these cases, we have that experience to say, okay, this is not going to work. If that's what you want, if you want this, this is the result. If you want this is the result. And, I think that's what it takes. And I don't know. I feel like, we've been practicing for 6 years now, I think, both of us, since 2018.
Yeah.
I feel like I'm starting to hit a stride, I'm not getting comfortable, but I feel like I've done enough cases. I've had enough feedback where I feel like, okay, I can advise patients properly. I feel like they will get the result that we talk about for the most part, right? Things can always happen, and if those things do happen, we're willing and have ways to address it, and I think it just takes having had cases where you're like, it just didn't turn out how I wanted it to. I tried. And again, you kind of get those iterations and fix it.
Yeah. I think in residency, they always talked about, 5 years out, it's like from 5 to 10 years out was like a sweet spot where you really hit your stride and where things are starting to feel like they should, because you're spending so much time in the weeds dealing with paperwork and administrative stuff and all of these things. We were trying to get things dialed in. And now you have a time where you've got enough cases under your belt, you've got enough volume and things are coming through that it's really starting to make a lot of sense. And I definitely feel that. I mean, I don't lose sleep over cases anymore. And I used to lose a lot of sleep.
Yeah.
A lot of sleep from like second year, third year, a really tough, technical case that I knew every part of. But when you're putting it all together for some of those big cases, wake up at 2 a.m., eyes wide open, just staring at the ceiling. My brain's like, okay, so first thing is going to be tumescent, and then we're going to do lipo, and then we're going to flip. It's just my brain's planning for the day while I should be sleeping. And now I wake up when my alarm goes off, or if my baby wakes up, of course.
Oh yeah, that's true. That's another whole element you bring into it.
Yes, the 16-month-old, the teething. Yeah. I didn't know that people had so many teeth.
No, why do they keep coming? And then they fall out and you get another group. Like, what's going on?
Why do you have to have 2 sets? We can't get the permanent ones out of the gate? Yeah.
Just give me those. I got permanent eyeballs and I'll grow new eyeballs. It's
like, I'm not a dentist, but it feels like, it just feels like a lot of teething. She probably could have made it through with just 2 of them. Would have been fine. Yeah.
You just got to open a can. That's all you need. Just the top 2.
just the chompers. That's all. That's all you need.
Love
but
it.
No, a lot of teeth. Love her to death, but a lot of teeth coming in.
Cute. So this is a question I get a lot, and I'm curious, actually, I want to know what you do in your practice, because I think everyone's a little different. There's advice from, anesthesia group and all this stuff, like, National Anesthesia Society, whatever. But so this patient says, I've lost weight on tirzepatide. How long should I be off of it before I plan a mommy makeover or mommy takeover? So again, for people that haven't heard of tirzepatide or Ozempic, semaglutide, these GLP-1.
Where have you been if you haven't heard of any of the GLP-1s?
The skinny shot, whatever people call it.
In a cave under a rock.
Yeah, it's wild. I think it's really changing even our field. I think as people are on this more and more, we're going to see it, especially as it becomes more widely available, comes into oral form that's effective. I think we're going to see more and more patients coming in with all these skin issues, because in the end, they're not going to be able to lose that skin. But what do you tell your patients, Sean? Like, what's your guys' kind of protocol in terms of stopping it, restarting it, all that?
Yeah. So for the anesthesia groups and for myself in the area, it's a minimum of a week hold. My preference is 2. I know that they kind of start at a week, and then some people are kind of scooting up. But a minimum of a week goal 2. Yeah. What about you?
And I think when I first started, it was like 4 weeks, because I was like, I'd be ultra conservative. And like I said, at the Academy of whatever anesthesia, they came out and said, hey, like, you can do it whatever, 2 weeks or whatever. So we're between 2 and 4 weeks, depends on the patient and some other factors. But mainly we do it 4 weeks because that's when our patients come in for pre-op. They're coming to see our nurses. So we just try to have all the medications, keep it consistent for them. Say, hey, for the next 4 weeks, we're going to hold you off of it. And then afterwards, we hold it for the same thing, about 4 weeks. And the main reason for that is for wound healing, because a lot of things that I see with patients when they're on these medications, if they're not properly getting the proteins and all the nutrients, they're not eating, they're literally starving themselves because they're not being managed. Someone just prescribed it for them on the internet and sent it to them. So these patients, literally, I've checked some of their albumin, their pre-albumin is like crazy low, and you're not going to heal anything in your body if you just can't have the stuff to heal it. And so that's why I stop it actually a little bit earlier, is because I want them to have a little bit of an appetite to be able to eat enough. Yeah. And then, we do supplement that with our nutritionist, and then she'll kind of work with them and all that. But
yeah, I mean, especially post-operatively for a tummy tuck, number one, like one of the major side effects of all of these can be low energy. It's like their energy is already 0, right? They're just like on E for weeks anyway. You don't need anything making that worse. And they don't eat a ton anyway from the muscle repair. I don't know what it's like in your practice, but it's like I'll have patients lose like 20, 30, 40, 50 pounds post-op because they're just not hungry, because there's less space after the muscle repair. It's like they're like, I eat a cracker and I'm full to the brim. So how are they supposed to get the protein that they need as the building blocks for healing if they're not hungry? And then you're adding a medication that it also makes you not hungry. It's like you will literally starve yourself to a wound complication is what will end up happening.
For sure. And it's a real thing. So I think For sure in plastics especially, we're creating all these large incisions and wounds, like you said, especially tummy tucks, extended tummy tucks, fleur-de-lis. You have to heal those wounds. And I think, as plastic surgeons, we dealt with that in training. We see people who had poor protein levels, a lot of patients that have decubitus ulcers, who may be paraplegic, quadriplegic, so they're kind of bed bound essentially. They're not getting enough protein. They're not getting, obviously, exercise out of the bed. So they're just kind of wasting away. And we've seen these wounds and complications. And so the first thing we do is, hey, let's check a pre-albumin, let's check their, all their labs. Let's see where their nutrition status is at. And then let's correct that before we do surgery, because we don't want to create more issues, expose them to more complications before they're tanked up. So, and I think this goes across the board. So not just in protein and things and levels, but like you kind of mentioned earlier about BMI, for a long time, my requirement for surgery was, let's get you to BMI of 30 and under. And then I've lowered it to 28. But we started our wellness clinic. And I think that's been a huge thing, because I don't tell patients they have to achieve a certain goal without being able to help them. Right. And so before I'd be like, oh yeah, go see your primary and just figure it out. But now it's like, no, we will help you, because I know that your results can be better. It can be safer for you. There's data to show that, as your BMI is closer to more of your goal weight, I don't use ideal weight, but a goal weight, I think you'll have better healing. You'll have better results. And, like I tell people, you're paying for this. It's not like this is an emergency mommy makeover. Like, you're putting your own money into this. So let's make sure that you get out of it what you want, And so that's been what we've been doing.
Yeah. Although it's like, I do see patients from time to time, right? They've already lost weight. They've already fought and kicked and scratched to get themselves to 33 and a half. And they're like, listen, doc, this is it, buddy. I'm not getting any lower than this. Because I talk to them about that. And it's like, for everybody, I always tell them that my cutoff for surgery, for surgical risk, is 35. My cutoff for optimal results is in the 20s. So I have a serious discussion with them of you can have the surgery now, or we can get you settled in and then figure out a way to get you where you want to be. And sometimes they're like, you know what? I'm paying good money. I'm going to take a lot of downtime. Let's get to where, let's get to 185 pounds. Let's get to where we want to be. But especially for the golden year glow ups, right? It's but it's 62. And she's like, Sonny,
that ain't happening.
This is as trim as I've been in the last 20 years. This is what it's going to be. So let's just make it happen, which, as long as they understand.
Exactly.
True informed consent. As long as they understand, I'm like, sure, let's do it. That's what we're here for.
No, I love that. I love that. Okay, I got one more question. And there's other ones, but we'll just do a second one. This is a good question for both of us. Do you do blood thinner injections after surgery? So there's injections, there's oral forms of blood thinners or anticoagulants. For me, I do a dose of heparin for any tummy tuck case. Literally before I even start the case, I will give 5,000 sub-Q heparin. And then they all go home with SCDs. And maybe we've talked about this before, and then for patients who have a higher risk, if we calculate their Caprini risk score, 5 and over, I will do a week of Lovenox just once a day. And my partners, they'll do Eliquis, they'll do oral. And so we're pretty aggressive on that. But again, I'd rather have a little bit of bleeding than a lot of clotting, So that's kind of my personal take on it, a little more aggressive. I don't know and that's definitely not the standard, but I would say, I've only had a couple of blood clots in the last 6 years out of thousands of patients, So I do think it relates to that, but we're doing a lot of surgery. I mean, this is every case is a 6-hour mommy makeover. It's not these are tons of, you look at the data. I remember the old papers in training. It's you combine anything with a tummy tuck, even liposuction, your risk of blood clots goes up way high, But I think adding these other elements can definitely reduce that risk. So do you have a certain protocol, or do you kind of go off of Caprini, or how do you?
I go off of Caprini. Yeah. And it's and I tend towards injectable. I do Lovenox if patients need it.
Cool. Yeah. But definitely not for everyone, obviously. Everyone does not need it,
No. I don't need that for every.
Some people are bloody. You're doing the case and you're like, what did this person
what is
eat?
Happening?
What are they doing? Yeah.
Yeah. Definitely took their full dose aspirin that morning. Yeah.
Okay. So I had a patient. This is funny. When I first started, she came from out of state. The nicest lady. Doing a tummy tuck on her, and she told me she was super bloody during the surgery, and she's in the recovery for about an hour. She goes back to her hotel, which is across the street. And then she calls our office. I'm doing my next case. And she's like, yeah, my drains are really bloody. You know, we're like, well, what are you doing? She's like, oh, I've just been walking laps up and down the hall. And she's literally 2 hours post tummy tuck, like literally up walking, you know, because she was just want to be active. And she's like, yeah, I drink a lot. I'm like, okay, so come over. We had to bring her back to the surgery center, monitor her for several hours. She didn't have a hematoma or anything. She was fine. I was like, hey, like, you need to chill out. We started talking to her. She's like, oh, like I drank all these Zip Fizz drinks. And I'm like, I didn't even know what Zip Fizz was. Have you heard of Zip Fizz?
No, I have no idea what that is.
Dude, I looked it up. You should look it up. It has so many strange ingredients in it. And like all of them, if you looked at the list of like things you should stop before surgery, they're all in there, you know? And I'm like, oh no. Yeah. Don't. So if you're patient on Zip Fizz, just tell them to stop it 2 weeks before.
Okay. I'll keep that in mind. Hold Zip Fizz. I'm going to put it on my list.
I actually had it one time. I think it's like a powder you add into like water or something. And it's just got like caffeine, but it has all these like weird things like, you know, a root of, you know, witch's elm.
Quinara
it has all
extract and all sorts of weird plant stuff that I don't know what it does. Yeah. I'm like, yeah, you're going to have to hold this.
Yeah, exactly.
That's a classic thing looking at medication lists, right? As doctors are like, hey, which one of these supplements should I stop? And I'm like, stop all of these.
Yeah.
Because I can't even pronounce this. You're going to have to stop it because I have no idea what this does. It's like, you better tell me that it causes like instantaneous death if you stop it. Otherwise we're going to go ahead and stop that. It's always a negotiation, though. You always have the one patient, because we always tell them it's like all supplements, all vitamins, just like stop them all. And then you'll have the one patient who would be like, well, if I don't take my magnesium, then I can't sleep. Can I take my magnesium? I'm like, that's fine. Fine, take your magnesium. Okay, like, it's always a negotiation. It's like you can get them back.
Yeah.
It's like, if you don't take your vitamin D, it gives you immediate depression. I'm like, fine, take your vitamin D. That's fine. We can let that one slide.
Love it.
Yeah. I actually did a patient do like the same thing after she had a tummy tuck. She was like doing laps in their cul-de-sac with a walker.
Oh my
gosh. She was worried about getting
blood clot.
Yeah, she was worried about getting a blood clot. It was like day one. Like, go sit down somewhere. When I tell people, I tell them it's like, you're up like 5, 6, 7 times a day. I mean, like to the bathroom to get some water.
Yeah,
you know,
not around the cul-de-sac.
Go get a snack. No, we're not pumping laps. It's like she didn't get a blood clot, that's for sure. But she was so swollen for so long because she was so active right out of the gate. It was not good.
Yeah, love active patients, but there's a certain level of it's a balance in everything. You know, it's like you don't want to be too sedentary, you don't want to be too active.
Yeah, it's like I need you moving around, but no pickleball. Like take it easy. Who are your toughest patients to keep under control? Like, activity wise, people doing too much after surgery?
Honestly, like I have a lot of fitness patients when I do a lot of subfascial surgery. So we're not cutting muscle, right? They're very fit. They work out. They're trying to maintain a certain level of, you know, body fat percentage, and, you know, they're competing or whatever it is. So obviously they try to time the surgery when they're not doing that stuff. But because their mentality is always like, go, 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 they want to have a very, very regimented down to the days of when they can resume what, you know, when can I do legs? When can I do arms? When can I do chest? When can I do treadmill? And so it's very regimented. And so those are the hardest, but I think, you know, they'll totally listen because they get that, okay, I'm paying for this. I want my results, but it's very difficult because it's hard for them. They can't sit still. Like this, your patient you're talking about moving around, like these patients, like that's all they do every day. They work out, you know? So it's like, oh, it's so hard for them. And I feel bad, but I'm like, hey, like I got to protect you right now because you want the result that you're paying for. You don't want to compromise that, you know? How about you?
Yeah, it's definitely the fitness people, but it's not the augmentations for me. It's my gynecomastia guys.
Oh, yeah.
It's like, seeing as I do so much top surgery, I was surprised that I was getting a fairly high volume of like chest lifts and gynecomastia just because you do so many operations working on the chest. People are like, okay, you like get it, I suppose. So it was definitely my super jacked gym bros who have like gigantic packs and they've got like a little bit of gynecomastia and they want it taken out, but they need liposuction to kind of get everything taken care of, and they've got to be in compression for 6 weeks, and then they've got swelling, and seems though you're not taking that much out, that even like a little bit of swelling makes it look like you accomplish nothing. So you have to like really keep them under control out of the gate. And I think it's especially bad because it's dudes, because dudes are just the worst at following like any instructions. I don't know. It's like, and they're never there with like their wife or girlfriend who will then actually force them to do it. Like they're just there with, they're just alone. They're just there with me. And they're like, yeah, I'm doing legs on like day 2, right? You know, it's like they're on a treadmill. I'm sure they're like working out right now. But yeah, I feel like those are my hardest guys. So every week when I see them, they come in like, what can I do? And then when I tell them what they can do, they're like, great, because I started that like 3 weeks ago.
Like, why'd you ask?
It's like, why are you even asking for my permission?
You're asking for forgiveness.
You've got it all figured out.
That's amazing.
But yeah, it's definitely the gynecomastia guys. That's a tough one for me.
Sean, it's been awesome. Another great episode. I think we went through a lot of fun topics, some questions even from some of our followers. So you guys, this is Plastic Surgery, a Cut Above. I'm Dr. Jerry Chittister. This is my co-host, my colleague, Dr. Sean McNally. Had another great episode here. So if you don't follow us on YouTube. We are on YouTube. We have a channel. So the full podcast is available there. You also get it on iTunes and Spotify. And then check us out on Instagram. We do have a Instagram handle. We'll give you, it's plasticsurgery.a.cut.above. If you type it in, you'll find it. But yeah, thank you guys for tuning in and for listening. Let us know in the comments, or you can DM us if it's through social media. If you have any questions that you want us to talk about or topics, we'd love to do that.